Okay, everybody. I'd like to call this meeting to order. 3, 4, 5, 6, 7, 8. Okay, starting a little bit late. We're backed up. And I'm going to do the chairman's prerogative. I am going to let our guest go first and present something I wish that I could have every legislator in here and the whole state to listen to it. We have perhaps one of the best things we've ever done as a legislature, a bill that we passed, and it's with now the Good Pill Pharmacy. And Kia, you want to get started? And I'm sorry we don't have a committee full of legislators for you. It's just one of those times.
Thank you so much for your time today, committee. We'd like to actually start with a short video shot here in Georgia.
I've had asthma since a baby. I'm allergic to grass, trees, being outside, things like that. If I rolled around the grass as a kid, I'd come in with welts all over me. As I got older, I also inherited high blood pressure. The asthma didn't never disappear like they say it will.
I had hyperlipidemia, and I suffered with anxiety attacks.
I was diagnosed in 2007 with diabetes. I had just bought my house. 1 year later, I lost my job, and then I lost my coverage, and I was not receiving any income at all.
I'm a diabetic, and when I lost my insurance, and then everything was out of pocket. The one medicine that I was on has gone up to $850 for a 30-day supply.
Finally, they said, you have really severe atrial fibrillation. The end result was, of course, you wind up with a boatload of medications that you have to take to keep everything ticking along at a reasonable rate. And I said, wow, how much is that going to be? And they said, that would be $1,800.
I was spending $1,700 a month for insurance for 2 people, and yet then I'm still dropping close to $1,000 for medicine.
My main medications are for mental illness. I'm bipolar. We look for those little cards, that they have, the discount cards, and we used that for quite some time. That was the best option that was out there.
Then I'll go and have to call around to different pharmacies trying to see who had the best price. You're still spending money because you're having to spend it in gas to try to get to the location that has the cheapest rate.
I went without medication for about 2-3 months. It was pretty dangerous.
Cost of living is high now. You either have a choice of choosing your bills or your medicine.
I went to a doctor, and I didn't have a job at the time, and she said, you really have to take this medication on a regular. What I'm gonna do is refer you to one of our pharmacists, and so that's when I discovered Good Pill.
Good Pill is a nonprofit home delivery pharmacy. Our focus is delivering affordable medications to everyday people. We send the medications directly to their home.
That's another barrier that we're removing. They don't have to find time or find transportation to get to a pharmacy to get their meds.
I don't even have to call for the refill. They automatically refill it and send it to me as well.
Good Pill does not charge for the medications that we dispense. There's just an administrative fee.
And even if they can't afford it, they can apply for financial assistance.
Every prescription would cost me $6, which is like such a big, huge blessing. A little while later, I couldn't even afford the $6. I didn't know where to turn. So the gentleman called me right away, and he stated, we're gonna take over your costs. So I said, that's great. That's a lifesaver.
Now that I'm able to live, it's so refreshing. I discovered that I could do art, something that I never tried to do.
It's been much, much easier. I can be more active with my kids. They were able just to be themselves and not have to worry about me.
With being able to know that I have this medicine, I don't have to worry about having a stroke or bleeding to death. It gives you peace of mind.
I can do a lot of things that I haven't been able to do. Now I can do stuff outside. I can go golfing, which I like to do.
Oh, I'll probably still have the headaches and just not able to function. But now that I have the medicine, I found myself more energized, and I feel a whole lot better. I really feel like Good Pill has saved my life.
I am just grateful and thankful for Good Pill for being there, because I don't think I would be sitting here having this conversation with y'all.
It's a breath of fresh air.
Well, before Kia starts speaking, I want to say to every legislator here, we got a couple of new ones. We did this. Those people were talking about a bill we passed, and that with a nonprofit and the help of Kia, it became a reality. And so I wish you'd go home, everybody in the audience, tell your friends about Good Pill, and it is truly helping Georgians all over, but Kia can tell you specifically.
Thank you all so much for having us today. My name is Kia Williams. I'm one of the co-founders of Serum and Good Pill. And this is really the story of legislative success. The legislature in the 2016-2017 legislative session actually came together here in Georgia and authorized the state's drug repository program. From that, we were able to launch Good Pill. Last legislative session, we were able to expand legislation to make it even easier to donate. And so this is really a success story of taking legislation into practice. It enables private and public partnerships to really do good in this country and in this state particularly. This video that was actually shot here in the Metro Atlanta area, actually those are all residents of the state of Georgia. And we are happy to say that we serve, because Good Pill is a home delivery pharmacy, it actually serves patients in every single county in the state of Georgia. So this is not just a Metro Atlanta resource, this is a statewide resource that the Georgia legislature enabled to happen, that enables people to get their prescription medications at a cost that they can afford. And so we just wanted to share today this as a resource to say Good Pill is open for business. It is available. It is a nonprofit home delivery pharmacy where anyone in the state of Georgia who is having trouble affording their prescription medications, either because they are uninsured or, and growingly, over 50% of the people we serve are underinsured, meaning they have some type of coverage, but still the out-of-pocket costs that they're expected to pay are just too much for them to be able to afford as prescription drug prices just continue to rise. And so what this program enables is organizations like manufacturers, wholesalers, hospitals, pharmacies to take the small amount of surplus that they have, that when you actually aggregate this up across the ecosystem in the healthcare system, actually amounts to over $11 billion of unused medicine that goes to waste in this country. So Georgia has the largest repository program and distribution system in the country because of the Georgia legislature's actions to make this all possible. And so to date, just sharing a couple statistics, besides just serving every part of the state, Good Pill has dispensed over 1 million prescriptions worth over, 1 million actual individual prescriptions worth over $85 million of medications. Last year in 2024, over 200,000 prescriptions alone, over $20 million of medications to folks who would otherwise have too high of cost to consistently afford their medications. And this spans the gamut between chronic conditions that we know cause huge impacts on our healthcare system, like diabetes and heart disease. It also spans medications like mental health. It also spans to medications for things like HIV, cancer oncology, et cetera. So we are currently able to distribute over basically the overlap between the most commonly prescribed medications in the U.S. that are not opioids, non-controlled substances. There's a over 75% overlap with the top 300 prescribed medications in this country. So in the event that someone needs a medication, there is a good chance that Good Pill will have it to fill. And because we rely on and utilize technology that Serum builds, we actually also are able to guarantee continued refills for those prescriptions. So this is not a one and done service where someone can get their heart disease medicine today and next month they're not able to. We are able to actually, because we have a diverse supply of donated inventory and medications, when we put a patient on a medication, are able to continuously give them refills at this affordable price for them going forward. And so really want to thank you all for listening to us today, and I have a couple action steps that I'm hoping you all take. Number one is we have materials here on Good Pill, and we're really hoping, we know for a fact that every single legislator has constituents that have too high of medical costs. In fact, 1 in 4 working age adults in this country report skipping, cutting in half, or taking medications every other day because the costs of medications are too high. We would love to be able to share information with you about Good Pill, and please refer over to us any constituent that you come across that is having trouble with their prescription medication costs. We have a team of patient navigators on site that can help get the prescriptions transferred in. We have clinical pharmacists that can even do advising if there's a therapeutic substitution that's necessary. This is a full service so that low-income folks can get the medical care and the prescription access that they need. And so my ask to all of you would be, I have materials that I will pass out, would be to please give us a call, email, text. We actually do all three. So we'll hopefully hear from each of you, and we're also happy to share materials that you can put in your offices, whether here in the Capitol or in your district, to share with your constituents.
Let me refresh everybody. What we're talking about, if you didn't catch it, if you're new, is the medicine that they use is medicine that is still good. They are a regulated pharmacy through our pharmacy board. They meet all the regulations of any pharmacy, plus public health has oversight over them, which is an added thing that most pharmacies do not have. But where they get their medication are from medicines that are on their way to being destroyed. Good medicines that are still within the time limits, nothing wrong with them. Just because of regulations from pharmacies when they have too much, or from producers that have produced too much of something, then they are reclaimed by Good Pill. We were the first, once, I believe, the first one to do it statewide. It is statewide. All a person has to do is fill out about a 5-minute application. If I'm wrong, tell me, Key, if I'm wrong. You don't have to go through all the hoops and prove your income like you do with the Medicaid. If you want to get on Medicaid, you're on the honor system. You fill that in, and they have a list that you can go out and see if your medicine is available. And if it is, you have the pharmacist, your physician, write the prescription and send it in just like any other prescription goes in. Or they can help you get your pharmacy to change it, where it's filled, to the pharmacy. Am I okay so far? I mean, they mail your medicine to you. What's it running now, Key? Is it about $6 for
a 30-day supply of most medications.
And don't you send out a 90-day supply of the medicine?
90-day supply, and that includes shipping.
And so for $6 for most meds, you get a 90-day supply for $6. I mean, it's amazing. I asked her when I went out to see it, and I'll take another field trip because you can't believe how all the checks and balances and how the machines work, and they read minds, I do believe, the machines, and all the safeguards. Like I say, it's a real pharmacy, and it's just unbelievable when I said, well, are you sure you're going to always have enough medicines? And Waikia said to me, there are enough medicines destroyed in the United States every year that every state could have the Good Pill pharmacy. They could be supplying, every single state could do exactly what we've done and send out medications to people low income, high income that are underinsured, lost their insurance, can't pay their copays. You know, you need to tell the story. I think that when you're sometimes forget, and people think that people are home and looking at the bills we pass. I don't believe that. Unless you've got one spectacular bill, they don't pay attention to it. But if you help them get their medicines when they can't afford it, do you think they'll forget it? No. They really won't. So we need to spread the word. And guess what this cost the state of Georgia? Zero. Zero to offer this to our patients. And I can't thank this committee and the committee members I've had in the past that stood with me to help me get this passed out of the committee, through the House, and over through the Senate, so that we can offer this service. And Kia, I can't thank you enough, and I can't thank the people who support you enough by donations. We had people all over the country when I went out the last time that are their backers and their donors that make this work. And we have one with us. I won't point her out. She might want to stay anonymous with today from New York. And we are so appreciative of the fact that they back you and they back this service. And I like to say, one of the developmental tasks of aging when you're old is to sit on your front porch and look back at your life and decide whether you're happy with it or not. And if you're not happy with your life when you get old, there isn't a lot of time to change it. But this is one thing. You can sit on your porch, those are the people that we have, and if you get the word out, and be very proud of what you did and help you be satisfied with what you've done with your life, because this is a biggie. And we have no way of getting the word out. It's word of mouth. So I wish everybody would send something out to their constituents, find some way to get the word out. Not that they need the business, but it's growing and they can handle more and they can help more Georgians, and that's what we're about. Kia, thank you very much for coming. Sorry about all the backup and the delay.
Thank you all so much for having us. And again, we invite everyone who would like to come see our facility out in Lawrenceville, Georgia. Would also invite anyone to come out, but please do reach out to us, and we are excited to serve this state.
And you have to see it. You really do. They've grown and moved 3 times, and the medicine comes in great big huge boxes, and it's all mixed in. It could be 100 different medicines in there. And they put them on this machine, conveyor belt, and it goes through. They take pictures, they stamp time things and things on them. And at the end, they've separated the medicines into like medicines. And of course, then that's checked by pharmacists and all, but it's a pretty amazing facility. The other thing they had, and you heard her say, if somebody doesn't get their medicine, and they know they've been on the medicine for a while, they'll call them. And then like the person the thing said, I couldn't afford the medicine, and they'll say, we'll go to where it doesn't even cost you the $6. So they're a perfect example of following up on patient care. So once again, thank you, and I really appreciate it.
Thank
you to the committee for letting me spread the word of goodwill and good pill, and having Kia come. Thanks, Kia.
Thank you.
We've gotten to be friends over the years of watching this grow, and we can do a lot more. We have one presentation, one bill, and that's House Bill 352, LC 570223. Okay? And Representative Seabolt.
Good afternoon, everybody. Thank you, Chair Lady Cooper, colleagues. Thank you for allowing me to present House Bill 352, LC 570223. We're making a simple yet significant amendment to a bill that our House unanimously passed last year, thanks to my good friend and colleague, Rep. Danny Mathis, and that Governor Kemp signed into law. But it turns out that words do matter. And on line 21, we're asking to remove the requirement of a daily insulin treatment to just an insulin treatment. And on line 22, we're including the condition of gestational diabetes. This amendment ensures that Medicaid will cover continuous glucose monitoring for pregnant women that are diagnosed with gestational diabetes if their physician prescribes it. So why is this important and necessary? Because gestational diabetes is not just a temporary condition. It presents serious health risks for both mother and baby. Managing blood sugar levels with precision is critical to preventing complications such as preterm birth, high birth weight, and the future development of type 2 diabetes. A continuous glucose monitor provides real-time data that helps expecting mothers maintain stable glucose levels, reducing the risk of emergency intervention and costly complications. The language of this amendment is clear and consistent with the original law. It simply ensures that Medicaid covers this essential tool when prescribed by a doctor. It removes an unintended gap in coverage and upholds our commitment to protecting maternal and infant health in Georgia. I think this is a common sense measure with broad support. It costs little but means everything to the health of expectant mothers and their babies. And I'll ask for your favorable consideration. I'm happy to take any questions.
Okay. I'm going to do it a little bit differently. Do we have somebody here from DCH? Okay. We seem to have a problem with line 21. And the reason I went ahead and, we're getting down, the days are counting off. I think we're probably the next legislative day will be day 9, or we'll have 9 days left before crossover. And this has come up, and I need to have DCH. I want the bill to succeed. It's important. And so I don't want to have something, have it go across or get to the governor's desk and have him veto because of it. Okay, so would you identify yourself and...
Yes, ma'am. Thank you. I'm Brandy Sylvan, Director of Government Relations with the Department of Community Health. We definitely, we do not have any concerns with the primary purpose of the legislation, which is line 22, which adds gestational diabetes as a condition for coverage for our CGM. In fact, in our guidelines, it is expressly listed as a condition that would qualify you for this coverage. However, we do have concerns with removing the requirement that insulin be administered daily. Excuse me. And this is based off of the clinical guidelines that are established by the American Diabetes Association, as well as, what was the other one? The American Association of Clinical Endocrinology. So this change would make it very difficult for us to administer an automated prior authorization requirement, and it is not in line with the clinical guidelines. So we don't have concerns with the gestational diabetes language, but line 21 is concerning to the department.
Okay, and why, if this is to let the doctor that's ordering this, if the recipient practitioner has concluded that the recipient or their caregiver has sufficient training in using this as evidenced by the provision of prescription, therefore, how is it that they need the fact that they were treated with at least one daily administration of insulin? That they know how?
Well,
and
I would be more than happy, because it's pretty in-depth, those clinical guideline documents, but I would be more than happy to share them with the committee members. But they do list the daily injections of insulin or daily administration of insulin as part of those guidelines for clinical best practices of who is ideal users of the CGMs.
Madam Chair, can I ask?
Yes, please,
So,
back to the author.
Is there no situation where they're taking insulin once a week and not daily?
I would assume that is what this language is attempting to address.
I don't think that's correct.
Okay.
Is the fear or the use of the monitor because the patient doesn't have to stick themselves and doesn't do finger sticks to follow is that one of the reasons to get adherence?
So on the automation piece, for our prior authorization criteria, when there is that daily administration of insulin, it allows us to pull clinical data that automates that PA process. So we do believe that by changing that, it would have to be a manual process that is going to make this a lot more complex and difficult for both our providers and our members to get this to the folks that need them.
What data are you getting?
What data are we getting?
When you automated from those daily sticks?
So I would have to get a little more detail from our pharmacy director on that.
Okay, can I fuss at the department some?
Yes, ma'am.
All right. Please don't do this to me again. I just found out this today. I'm really between a rock and a hard place. Is there some way that you would have an amendment that this could be written in a different way that would?
The amendment we would recommend is not changing anything on line 21.
Is the reason that, okay, behind this, and this is for Medicaid patients, is that if you don't have this in there, somebody that only took one injection a week would be eligible for the monitor when they really didn't need it or not. So it would open it up to everybody in Medicaid that is a diabetic on insulin to have it.
So when we create our PA criteria, we rely heavily on clinical guidelines. And we did write that policy to align with those guidelines. If to get a little further into the weeds of why that distinction is, I would need to get a little more detail from our pharmacy team.
Okay, we have some questions. Representative Oliver.
Thank you, Madam Chair. I've not been paying close enough attention, forgive me. You are objecting to the striking of the language, at least one daily administration.
Yes, ma'am, that's correct.
And the reason you're objecting is that you want to limit this option to only daily users of diabetes.
Yes, ma'am.
Okay. And you used some initials in your initial presentation, CT something?
CGM, continuous glucose monitor. That's what we're talking about coverage
okay,
for.
And that is the particular device. It's a device. It's not a pill. It's
yes,
not
ma'am. Correct.
And that is the kind of thing that people wear on their arm or the port or.
Correct. And you can find out where your blood sugar levels are at any point.
And so this bill was introduced last week, and this is the first time the author has heard about this objection today?
Yes, ma'am.
Okay. Thank you.
Representative Sharper.
Okay, thank you, Chairman. Thank you also. Thank you for bringing this bill as well. But me just looking at that, most practitioners that really diagnose people with diabetes mellitus, that you may be on the insulin every day. In most cases, and I'm looking at when people are using these machines every day and then the other ones that you're getting ready to approve of them, I think it should be some type of leveling. I mean, I don't know if anything can be changed, but there should be a correlation. So what I'm thinking is the consistency of a person getting insulin every day and the consistency of the monitors should basically have some type of reflection of each other. But if a person isn't taking insulin every day, you may not be able to get the proper reading and the proper information you need from this monitor to that monitor to know if it's working or not or what needs to be done. But I think it needs to be consistent, really, honestly, on a daily basis of that insulin being used so that it can also have the data that you need at the end of the day to be able to make sure both of the whole system is working like you want it. So that's just my take on, I don't know if that's what y'all are looking at, making sure it's happening, because if you don't have that, you won't really know how well the machine is working with the people that you're trying to get it for. So that's just my take on it.
Okay, who we got? Representative Reese.
Yes, sir. Thank you, Madam Chairwoman. Bear with me here. I'm just trying to make sure I fully understand what we're saying. So right now, as is written, line 21 qualifies someone that does a daily administration of insulin for coverage through Medicare, right?
Medicaid.
Medicaid. And what we're proposing is that it be open up so that if I'm taking insulin every 2 days or every 4 days or once a week, that I have access for Medicaid to pay for this device.
Yes, sir.
And if I heard you correctly, the primary objection, and please correct me if I'm wrong, but the primary objection here is that internal administrators will have to do more work because it's automated and it may become manual. So we're actually contemplating not giving this device to people because somebody may have to do a little bit of manual work.
So I don't think that's quite an accurate
Okay, well, make it
portrayal.
accurate for me.
It's more about making the prior authorization process more streamlined, so it's less of a burden on our members and providers to be able to request that and get the approval.
So to put to where the goats can get it, as they used to say where I'm from. What this language would do is potentially interrupt that automation process if we go with the proposed language, which means somebody will have to do it manually.
And slow that process.
But it also means if we do, more Georgians that depend on insulin will have access to this device, which we know is helpful through Medicaid.
I think there is also some concern that some of the people that are currently receiving this coverage may find that their provider is not easily familiar with that process, and it could lead some people to not be getting the device because they're not doing that PA request and following that process. But again, I also want to come back to the clinical guidelines, because that really is what we base our policy largely on, is the feedback from the experts in whatever the given field is.
Representative Reese,
Okay.
I'm sure there's exceptions to this, but I've never heard, Dr. Algo, I've never heard of anybody getting insulin every other day or every 4 days. I mean, usually you're either on it or you're on the new medicines that only require a weekly injection.
So my question to the speaker is, isn't it true that for insulin-dependent gestational diabetes mellitus, that continuous glucose monitoring is the standard of care?
And we have no concerns with the gestational diabetes addition to the bill. So that language is not concerning to the department.
When we say insulin-dependent diabetes mellitus, it does not have a time frame for the frequency of insulin administration. So that's why I asked the question that way. Isn't it the standard of care that people requiring insulin administration, regardless of the treatment interval, the standard of care is continuous glucometry?
I'm relying on the information that this was pulled from those ADA guidelines. But again, I'm happy to have a conversation with folks that are a little bit more informed on the clinical aspects of that.
Okay. Okay. What is the purpose, or what does the committee want to do about the bill? What?
Second.
Okay, we have a bill to do pass and move. Okay. Before we do that, we have one person or somebody that wants to talk about it. Okay. Carolyn Grant, I'm sorry. You waive? Okay, good. Okay, we have him do pass in a second. Do we have any amendments to the bill? No, hearing none. Okay, what about, there do need to make one amendment. Thank you for reminding me. On line 12. I take it this is when the bill was introduced last year. It says on or after July 1st of 23. Okay, we need to change that. Is there any disagreement with the committee if we have our lawyer change that to July 1st, 2025? Anybody? Everybody in favor? Okay, so we'll change that. Okay, Kate, did you hear us?
Yes.
Okay. Pardon?
The opinion of legislative council is not necessarily needed to change it, given the effective date being July 1 of 2025, but that's fine, we can change it.
Okay, you can change it. Okay, just make sure it's legal. Okay, she's saying that legislative council does not believe they need us to vote on it to change it, the year, so it is now July 1st, 2025 on line 12. Everybody in favor of the passage of House Bill 352, say aye. Aye. Anyone opposed, no. Okay, the ayes have it, and thank you very much. And there's one other health on Thursday, February the 20th, from 8 a.m. to 2 p.m., Quest Diagnostics will be here. They will have one of their trailers out there, and you can talk to them about colorectal cancer screenings, and please do. We are picking up rectal and colon cancer at younger ages and in a greater degree, so people do need to be screened. This is something new. And also diabetes and pre-diabetes, diabetes. So please stop by the trailer and talk to people. And they will do on-site hemoglobin and blood sugar testing, and I'll give you a home kit for colorectal cancer screening. And if you don't need it, you probably know somebody that does. And I'm not kidding, it is becoming a major problem with people not getting tested and their cancer, colon cancer and all, being picked up at later dates and therefore being further along and causing much more serious problems. So thank you very much. We are adjourned.